Did you know that in a landmark study published in JAMA, researchers reviewed actual clinical encounters and found that only 9% of medical decisions met the basic threshold for informed consent? 9%. Today I'm going to tell you what informed consent actually requires by law and by ethical code, and why almost every patient in America is being denied it every single day. You'll see why your doctor is legally and ethically required to discuss alternatives to any treatment they recommend, including the option of doing nothing. You'll see how the way risks are presented to you is often designed, consciously or not, to steer your decision rather than inform it. And you'll see what happens when you understand your rights and know exactly what to ask. This affects every medical appointment you have ever had, and every one you will ever have. It affects your children's medical appointments. It affects your parents. Anyone who has ever sat in a doctor's office and been handed a prescription, a surgical recommendation, or a form to sign before being told what the alternatives are. This is for you. I recently asked a well-informed colleague to tell me their understanding of informed consent. Their answer was something I've heard from a lot of people. They said it seemed like a formality, a thing you do to tick a box. Sign here, initial here. That's it. And the moment they said that, I knew exactly why informed consent fails as often as it does. Because if the patient thinks it's a formality, and the doctor thinks it's a formality, it becomes a formality. But it isn't one. Societies ritualize the things that matter. We make things formal precisely because they are important. And informed consent is perhaps the most important formal obligation in all of medicine, because it is the mechanism by which everything else in medicine is supposed to answer to you. By the end of this video, you are going to understand why the doctor's obligation to present alternatives is not optional, not discretionary, and not satisfied by a signature on a form. Let's start with what informed consent actually requires, not what usually happens, what the law and the medical ethics codes require. In 2012, Hall, Prochaska, and Fink published a rigorous examination of informed consent standards in the Canadian Medical Association Journal. Their conclusion was unambiguous. An authorization is not informed unless the physician explicitly discloses the diagnosis, the nature and purpose of the proposed intervention, its risks and benefits, and crucially, a thorough discussion of reasonable alternatives, including the option of no treatment, along with the corresponding risks and benefits of each alternative. Not the option the doctor prefers. All reasonable options, including doing nothing. Omitting this step, they write, fundamentally distorts the decision matrix a patient faces, and thereby invalidates the autonomy the consent doctrine is supposed to protect. In 2015, the United Kingdom Supreme Court went further. In the case of Montgomery v. Lanarkshire Health Board, the court explicitly rejected the old physician-centered standard, where the doctor decided what was worth disclosing, and replaced it with a patient-centered standard. Clinicians must now ensure the patient understands the material risks of a procedure and the reasonable alternative treatments available. What a reasonable patient would want to know, not what a reasonable physician decides to tell them. In the United States, the JAMA standard is equally direct. Spatz, Krumholtz, and Moulton wrote in 2016 that the reasonable patient standard requires physicians to disclose all information a reasonable person would find material, and that explicitly includes alternative treatments. Legal liability arises not merely when harm occurs, but when a patient is denied the right to evaluate options on equal footing. So, if the law is this clear and the ethical codes are this explicit, what actually happens in clinical practice? Braddock and colleagues at the University of Washington wanted to know. They obtained audio recordings of actual clinical encounters across primary care and surgical practices. They defined 6 elements of complete informed decision-making, one of which was discussion of alternatives. Then they scored every recorded encounter. In outpatient practice, only 9.0% of decisions met their threshold for completeness. 9%. In surgery, it was similarly low. Most decisions were made with the patient receiving a diagnosis and a recommended treatment, and nothing else. No alternatives presented. No options weighed. No treatment option mentioned. The consent form got signed, but the consent process never happened. And here is the contrast that should bother you. In a 2012 study published in Patient Education and Counseling, researchers asked older adults how important each component of informed decision-making was to them. The results were essentially unanimous. 97 to 100% of patients rated discussion of alternatives as either somewhat or very important. 100% wanted it. 9% got it. What patients want? 97 to 100% want alternatives discussed. What patients get? 9% of clinical encounters include them. This is not a small gap. This is a system-wide failure. Here's what most patients don't realize. Most doctors don't realize it either, or if they do, they've rationalized it away. The requirement to disclose alternatives is not a suggestion. It is not an ideal. It is a codified obligation embedded in the AMA Code of Medical Ethics, in the standards of the American College of Surgeons, in the ACOG Guidelines for Obstetrics and Gynecology, and in the Joint Commission's requirements for hospital accreditation. Every major medical body in the United States has signed off on this standard, and the rate of compliance, when measured directly in clinical practice, is 9%. Even when doctors do present some information about a treatment, there is a second problem: how that information is framed. And framing changes everything. Consider two ways of presenting the same data. Option 1. This treatment reduces your risk of a cardiac event by 50%. Option 2. This treatment reduces your risk from 2% to 1%. Same drug, same data. But the first version sounds dramatically more compelling than the second. The first is relative risk reduction. The second is absolute risk reduction. Relative risk reduction is almost always the number used in clinical conversations because it sounds better. Absolute risk reduction is the number that tells you what actually changes for you as an individual. This is the framing effect, and it operates in every direction. Clinicians who prefer a particular treatment can present it using relative risk language. Presenting only one framing while omitting the other distorts the choice. Patients deserve both numbers. They rarely get them. And the most neglected option of all is the one that requires no numbers at all: watchful waiting and no treatment. In a wide range of clinical situations, musculoskeletal pain, mild hypertension, early-stage slow-growing cancers, benign growths, minor thyroid nodules, doing nothing and monitoring the situation is a completely legitimate medical choice. But this option is routinely omitted from clinical conversations, either because of revenue pressures on the provider side, performance targets, or simply because it has never been the default script. Patients overestimate the benefits of treatment and underestimate the harms. Disclosure of the no treatment option corrects this asymmetry. It is required. It is omitted. In late 2025, a physician on social media posted about this exact issue. The responses that followed revealed something important. The community of clinicians has developed an elaborate set of rationales for why it is acceptable to omit alternatives from informed consent. They fall into 4 groups. None of them hold under ethical or legal scrutiny. The first category is economic. Physicians argue that time pressure and low reimbursement rates make thorough consent impossible. The frustration with the payment system is understandable, but it does not erase the ethical obligation. Legal duties do not disappear because they are economically inconvenient. The second category is paternalistic. Physicians argue that presenting alternatives would confuse the patient or undermine trust in the recommendation. But the duty to guide a patient and the duty to enumerate alternatives are not mutually exclusive. You can recommend and inform at the same time. Failing to inform transforms the recommendation into an unconsented directive. The third category is defensive, and this is the most revealing one. Some physicians argue that presenting options is just a liability shield, but that framing proves the point. It protects physicians from liability because the law requires it. The law created that protection because omitting alternatives is negligence. The liability is real, and the legal protection is real because the patient's right is real. The fourth category is procedural dismissiveness. Physicians say this is not standard of care, or they treat shared decision-making as bureaucratic theater. But standard of care reflects what typically happens, and what typically happens can be ethically deficient. Routine deviation from the informed consent standard has normalized the failure. That normalization is not justification. Payment constraints do not nullify ethical duties. Recommendations must follow, not replace. Full disclosure. Common practice, when it conflicts with law and ethics, is evidence of systemic failure, not justification for it. Here are 5 things you can say and ask in any clinical encounter before you sign anything or agree to anything. 1. What are all the reasonable alternatives to what you're recommending? Include the option of watchful waiting and no treatment. 2. Can you give me the absolute risk reduction of this treatment, not just the relative risk? 3. What happens if I do nothing? What is the natural progression of this condition without treatment? 4. Are there any contraindications based on my personal health history, family history, or current medications that would change the risk-benefit calculation for me specifically? 5. For any vaccine or preventive intervention, ask for the manufacturer's package insert. Ask what post-market surveillance data exists. Ask whether the long-term safety profile for your specific combination of circumstances has been established. These are not hostile questions. They are the questions informed consent requires a physician to be able to answer. We began with a colleague who called informed consent a formality. Here is the answer to that. A formality is something we do that means nothing. Informed consent, done correctly, is the mechanism by which medicine remains answerable to the person being treated. It is the legal and ethical barrier between medical authority and medical coercion. The fact that it is routinely reduced to a formality does not make it one. It makes the reduction a failure. A failure with legal, ethical, and personal consequences for every patient who is handed one option and asked to sign. You are entitled to the full picture. Ask for it. If this video matters to you, share it. With your family. With your doctor. The full companion article, with every citation and the complete analysis, is at Popular Rationalism on Substack. Link in the description. The work of building an independent research and education infrastructure that holds medicine to its own standards is what IPAC EDU exists to do. Support it at ipa-knowledge.org. Take care of yourselves. And the next time someone hands you a form to sign, read it and ask what it doesn't say.